When we're thinking about the military, you also want to think about veterans and service members with brain injury are more likely to have repeat injuries and polytrauma. This can include, we talked about this a little bit earlier, amputation, spinal cord injury, visual impairment, stress disorder. They can have burns, right? They can have chemical burns in their lungs. And again, brain injury and polytrauma in terms of military settings is considered the signature or in the invisible injuries of the Iraq and Afghanistan wars. So in terms of VHA polytrauma system of care, if any of you guys are working with that entity, it's set up a little bit different. So they usually have a rehab physician, a nurse, a social worker, or a case manager, speech and language, PT, OT, and then a clinical psychologist. The way it works at the Haley VA here in Tampa, we have a lot of our students doing their internships there. The VA VR, within the TBI, they have a TBI section here in physical medicine and rehab. And though they have a set of voc rehab counselors that just work with TBI. Then they have something called the CWT, or the Compensative Work Therapy Program, and those folks work a lot with different types of injuries and SCI. So sometimes you might have 2 different rehab programs within a hospital. Now, the Haley VA here in Tampa is one of the 5 polytraumas. So it's much larger and they have a lot more services. So some of the smaller VAs might be set up a little bit differently. So then you got your voc rehab specialists on the outside. The DVBIC, or the Defense and Veterans Brain Injury Center, is where you can find information for care for service members following TBI. And again, it's at no cost. And going to ethics and behavioral health, you want to think about the philosophy of morals and moral choice. And there's a lot of literature on this. People have done, completed dissertations on this topic, but just really thinking about ethically who you are, where you are, and how you serve the people that you serve. And making sure that whatever discipline that you come from, social work, rehab, psychology, counseling, that you have your code of ethics and that you know it and that you follow it. If you're in a state where you're mandated or licensed and the laws supersede that of your credentialing body, then you follow that, of course. But you want to make sure that you understand your code of ethics, that you read it, and that you go to it when you have trouble. And remembering that most codes, if not all of them, oh, good, you got a question about self-care. Yes, I'm going to talk about that too. That's great, great question. So for all counseling and behavioral health professionals, ethical codes prohibit discrimination. So even if you don't think you do it, you might. So just maybe take another step back and another look at yourself. If you've ever laughed at a racial joke, or if you've ever laughed at a blonde joke, had a few of those in my life, or a racial joke, or a socioeconomic status joke, and you laughed at it. You're human. I'm sure I've laughed at some of those jokes. I can't say that I haven't, but just thinking about kind of, if we're going to talk the talk, we should walk the walk, making sure that we do our best to not continue that type of behavior, because really it's not very helpful for anyone. So if you want to look at a way that you can incorporate multicultural ethics into behavioral health, there is a transcultural integrative model that's been well known and used. And so this combines other ethical models with multicultural counseling theories. And the reference model addresses dilemmas faced in interactions with clients from different cultural backgrounds. So what you want to think about is awareness and fact-finding, understanding how the dilemma may affect the different stakeholders, understanding how your own values kind of can impact what you're doing and how you view it, and then recognizing how you feel about it, right? I took a multicultural counseling class a couple of years ago online, because when I was in school, we really didn't have one. And so I went in thinking, I'm good. I am so good. I love everybody. The world is great. I don't see color. I don't see any of this. It's not my fault things have happened to people from different backgrounds. And after completing that course, I thought, wow, my life has been very different than other people's. It doesn't mean I'm a bad person, but I need to know that some of the things I've experienced are very different. Our counseling theories were created by Protestant males, right? And so there's nothing wrong with that, but maybe that model is not going to work with somebody from a different background. So I had a wake up moment where I just thought a little bit differently about things and realized that, there's probably some things that I didn't really think about before. And it was good for me to go through that. So I encourage you to always continue with your CEUs, to not change who you are as a core person, but to understand that, people are going to think and see differently than you. That's pretty much the bottom line. And have experienced different things than you. So when we talk about ethics, you want to think about, okay, I got to formulate my course of action, analyze the information that I've gathered, think about laws and regulations. We have to do that. Ensure that the course of action aligns with different worldviews of stakeholders, examine the pros and the cons, right, of what we're going to do, and then always seek advice from people that might have more expertise than you. Even after being in the field, as long as I've been in the field, I still bounce things off of former colleagues, former professors, other people that are experts in certain areas of rehab that are far beyond what I have studied. And I'm always learning, always taking courses. I just completed a course in dialectical behavior therapy because that wasn't something we really learned when we were in school. And I think it's really important, especially when you work with someone with borderline personality. I also took a course on biofeedback, just so I could understand it and how that could benefit people that don't want to take medications and that are managing chronic pain. So always take the opportunity to learn and to continue to grow as a professional. And then that way you're doing the best that you can to be able to provide the best services you can to your clients. And then you want to think about the best course of action. Again, it's important to identify challenges, knowing the attitudes of other service providers, systems, and employers, being able to determine the readiness of the individual to confront and handle negative reactions and disclosure, and then thinking about contextual influences with some of you have already talked about here, the family. Sometimes there's helicopter parents or families aren't supportive of the rehab process. There may be transportation issues, and there may be, fortunately, some discrimination. It's out there. And then you want to make sure that you implement, document, and evaluate. So you want to identify resources and solutions that are relevant for addressing potential challenges. Another thing you want to think about is that counselors bring different viewpoints and that there may be different worldviews, different awareness of the counselor, different awareness of the client. There may be, differences in the counseling relationship, and just thinking about that. And like I said, all of this education and these things that are being talked about are not to change who we are as people. It's to change how we understand how other people are as people. And that's all that pretty much when I teach my courses, ask my students to do. Just think about who you are and where you come from, and think about somebody else and where they come from, and think about how, that could affect the counseling relationship. So I think if we do that, we could probably get further with our clients and, get to the ultimate goal of having them get rehabilitated, become employed, be able to deal with some of the problems and challenges that they're dealing with. And realizing that we're not perfect people, we're going to make mistakes, and that we're human, and having that grace with ourselves and having that grace with our clients. Now you pull in disability on top of all this other stuff that we're talking about, we've really got a lot of things that we have to untangle and consider. So for you as counselors, just realizing that there's opportunity to grow as a person and an opportunity to grow in your skills as a counselor and a therapist. And then I've got some questions here, which I'm really happy that you all brought up. And I've been making a lot of slides for a lot of different things lately. I've got a grant I'm working with Nebraska doing TBI counselor competency. So if you haven't seen that article, we just had an article come out in Journal of Voc Rehab this past summer, and it was on TBI counselor competencies, which I can certainly share with the group. There's a few things I'm going to be sending after this presentation. But I realized in this that I did not include the severity index, which maybe when I was making this was thinking you all were already pretty well versed with TBI, but I'll pull that up and I'll share that with you all because we still have some time. It's 2:30. And then I do want to talk about self-care. How important is self-care? This is from Christoline. I believe I said her name right. And apologies if I didn't. It's very important. Self-care is important to all clinicians working with all clients, especially people with TBI. It's hard to not take things personally. And sometimes it's not personal with TBI. They just don't have a brain filter. So as clinicians, burnout and self-care is really important. And I have something that I would like to share with you that I didn't really incorporate into this presentation, but since this came up, it seems to be relevant. The next question from Tammy is self-care inherent or does it require training, education, supportive resources? I think it requires training, education, and resources. Over my life as a counselor, I've had to learn how to leave it at the office, not bring it home, not think about it at night, not think about my client that I ran into at the gas station who I know has 5 kids and has no money and asked me for $5 for a gallon of milk. And I know he's going to go in there and buy that milk and take it home to his family. But if I give him $5, I have to give everybody else $5. I can't give my clients money, right? That's unethical. So being able to parse all of that out over time, I've had to be okay with, how I interact with my clients and how I, set boundaries with my clients and how we have our own type of self-care. So what I'd like to do right now is just to stop sharing my screen for a moment, and I would like to pull up the self-care resources that I have. So I'm just going to go off the Zoom for 1 minute, and then we'll open it up for questions as well. So let me just do this.
And thank you so much for that, Dr. Dillahunt. And while you are pulling that up, thank you so much for the presentation. And for anyone who has questions right now, you can just put them in the chat while Dr. Dillahunt is pulling this up. And then we'll go into that afterwards.
Yeah, I just need like maybe 1 or 2 minutes. Let's see here. I don't think we teach it enough, honestly. I'm going to put it in the chat. Now, this is specific to social workers, but certainly will be just fine for those that are rehab counselors. And this is publicly available. And I just shared this with my students this week, actually. And it's really important. And then I want to pull up the severity, and I'll get this sent to you all as well. Like I said, I think I made about 10 PowerPoints in the last 2 weeks. So sometimes I forget and things overlap. Brain injury. Let's see, brain injury. Yeah, I just did a whole voc rehab TBI competency video. PowerPoint, pardon me. Okay. Yeah. And again, I can just send you a copy of these. It's not a problem. All right. Okay, so let me first share this, and then we'll go through the links. So what you have here are some severity definitions, and I'll make sure I get you a copy of these. So a mild brain injury is loss of consciousness for less than 30 minutes, possibly no loss of consciousness. All right, this would be concussion, mild brain injury, concussion, concussion, mild brain injury, same thing. How they manifest can be different. Glasgow Coma Scale of 13 to 15, and I'll talk about GCS in a moment. Post-traumatic amnesia, meaning they don't remember much for like less than 24 hours. And this could include temporary or permanently altered or mental neurological state. And this could also include some post-concussion symptoms. Moderate brain injury is when you're in a coma for 20 to 30 minutes, but less than a day. This is the GCS of 9 to 12. The higher the GCS, the more responsive someone is. That's how you remember that. This could include some fractures, some bruising, or some bleeding. This is usually when there's imaging signs on certain different types of imaging, and this is when there might be some longer term problems. Someone that has a severe TBI is in a coma longer than 24 hours, often lasting days or weeks, and they have a pretty low GCS of 3 to 8. Usually significant bruising and bleeding and signs on imaging, as well as long-term impairments. So GCS, which is the Glasgow Coma Scale, there are a few different measures of severity of brain injury. This is one of the more common ones. There's also the GOSI, but this is one that's most, I would say, most people recognize and understand. So if you think about somebody when they're in an accident and the first responder gets onto the scene and they say, "Can you hear me? Can you squeeze my fingers? Can you blink your eyes for me? Can you tell me what day it is? Can you tell me what time it is?" That's what they're assessing here. They're assessing this eye-opening verbal response and motor response. And like I said before, the score ranges from 3 to 15, with 3 being pretty much not responsive to 15 being okay. In terms of eye-opening, a 4, which is the highest out of 1 to 4, would be spontaneous, right? In terms of verbal response, someone that is oriented to person, place, month, and year, they're going to have a 5, where someone that's not responding at all is going to have a score of 1. Then someone who obeys commands like squeezing a finger, raising their hand, is going to have a 6 or a higher score. Then someone who can't respond at all is going to have no motor response. So that's pretty much, you know, we could have included that in the presentation. I kind of thought the background was already here, but what I'm going to do is make sure I have this information for you all. And we also didn't go into, you know, the different types of the brain and the lobes. But what I can do is incorporate some of this back into this training, and the Model Systems Knowledge Translation Center has some really great fact sheets that I think will also be very useful for us, and some of them are specific to helping people get back to work. But again, the lobes of the brain, where the brain is affected, can affect the outcomes and the symptoms a person experiences following injury. So if someone's injured in the back of their head and their occipital lobe, they could have vision problems. If someone, you know, gets hit in the front of the head, which is very common with sports and, you know, hitting heads on steering wheels and falling off bikes and falling off trampolines, well, that could be problematic because that's in the area of the frontal lobe. And this is where people, you know, are able to determine black and white, pay attention, have flexible thinking, you know, have normative social skills, and be flexible in their thinking. So again, when you're thinking about brain injury, it is also important to know which areas of the brain have been affected, because that can affect how their symptoms present and manifest. Okay, and so I'm going to click on these links now, and I'm going to see if this is going to share, and just bear with me a moment because it might not be sharing. It probably isn't, but I will certainly share it. Let's see here.
And we will make sure to let you know when it is sharing.
Great, that's perfect. Go team. Okay.
We can see it. The School of Social
Yay,
Work.
I'm getting better. See, it's improvement, repetition. Okay, so this is the School of Social Work, and I know we're not social workers, but there are some things that overlap with our profession. So what they've got here is they've got a really nice page that has self-care assessments, exercises, and activities. So these pages provide additional self-care resources. They are intended to supplement a basic self-care plan. So they have checklists and exercises and activities, which I think we can do a better job, at least I know I can do a better job as a professor, helping our students kind of understand the importance of self-care, leaving it at the office, understanding compassion, fatigue, and burnout. So in terms of taking care of yourself, what we have on the screen here is a link that goes to a way for you to start developing your self-care plan with specific self-care assessments. And then there's a note here and it says, the assessments below are to assist you in understanding various aspects of your well-being. They may also be useful for you in your work with your clients. So they have some pluses here with some drop downs. And these are for childhood trauma, stress, burnout and secondary vicarious traumatization, compassion, satisfaction, and aspects of personality. So I'm going to go down here to stress, and I've opened this up, and then it has a link to a life stress inventory. Where's your time going, to seeing how you're spending your time and how, it never feels like there's enough. And I'm going to give you a clue. Get off Facebook. I'm sorry, I just have to say it. Once I stopped being on Facebook, I just got so much more time. But that was what I needed to do for me to take care of my self-care. There's a link here to stress warning and symptoms, an assessment for, are you stressed? And then a lifestyle behavior checklist. And so that's under stress. So you can do these on your own. You don't have to give them to anybody, but they might be good for you to kind of see where you are. There's also, I believe it's PAR Inc. has an OSI or an occupational stress inventory as well, but you have to purchase those. The burnout and secondary vicarious traumatization. This is real. This secondary trauma, I've experienced it. It was not pleasant. I was working with a client that had a lot of things happen to her that were very violent, and it was hard for me to leave it at the office. I kept thinking about it, and I had to, really process it. And I processed it with my mentor. Something that I think is really important for all of us is always be mentoring someone, and always have a mentor, no matter what age you are. So I have a mentor who is 65, and he's been in the field. He's a clinical psychologist, and he's been in the field for many, many years. He's brilliant. And I had to bounce some of this stuff with him. I also bounced off of, I had to work with a family with a child with some child abuse that was a result of state employees. And that was very upsetting to me because I'm a mother and I have a child. Of course, that's going to affect me. So being able to, process that, compartmentalize that, and realize that we're humans and that we care about people. That's why we're in this field, right? We want to help people. We want to care about them. And when things happen to people and we see people suffer, it usually affects us in some way. We feel it, right? We don't usually like to see people suffer. Most of us as counselors would agree with that, I would say. That's a very fair assessment. So in terms of burnout and secondary vicarious traumatization, there's a complete are you burning out scale, and help you determine, if you are experiencing feelings common with burnout. And then if you score high on that, you can, and you work with trauma clients and it's had a lingering effect in your life, you want to consider completing the compassion, satisfaction, and fatigue scale. So the burnout is a scale, the burnout is a subscale on this measure, along with secondary traumatic stress or vicarious traumatization, which together can result in what we call compassion fatigue. And this happens, and it happens to us, and that's why there's such a high turnover in social services. So being able to get a pulse on this and to gauge where we are with ourselves and with our work and with our clients is going to really help us not only stay well ourselves, but it's going to help us stay in our job longer and do a better job with our clients. It doesn't help our clients when we leave. It doesn't help our clients the amount of turnover we have in our field. In some cases, it actually can harm them. I told you I was on the CRCC ethics committee, and there are things that I see that counselors do, and we have to remember by our code of ethics, our clients come first, but we can't take care of our clients if we don't take care of ourselves. And it's not called being selfish. It's what we have to do to be able to stay well and fit for our duty as counselors and for the people that we serve. And then there's articles here. If you're feeling some of this secondary traumatic stress, it's a self-care bibliography. You've also got a compassion satisfaction link here. And then, aspects of personality. So this was kind of a nice image that they have here on the site. And again, it is specific to social work, but it talks about how to flourish in social service. So how to preserve personal longevity, happiness, and relationships in your career. So some common ailments on this image that I put up on the screen is burnout, compassion fatigue, and secondary traumatic stress. And it's got a quote down here, and it says, a feeling of depletion leads to dysfunction. a practitioner becomes increasingly inoperative. Steps to self-care. Self-care refers to selected actions that restore balance in our personal and professional lives. Not just an add-on activity, self-care is also a state of mind through development of self-awareness, self-regulation, and self-efficacy. What they recommend is exercising, surprise, surprise, right? Everyone's always telling us to exercise. When do I have time to exercise? So what they say is just do it 3 days a week. It improves happiness by 10 to 20% and increases work productivity by 15%. So even if it's a 10-minute walk after dinner, take it. You can do a 10-minute walk. You can meditate for 5 minutes. You can find 5 minutes in a day to meditate. There are a lot of apps that are out there that are amazing. One of the things I do for self-care is I've been going to acupuncture for a long time. And I was getting my treatment yesterday, which I schedule like every other appointment, and it's in my calendar. And I was talking to my acupuncturist and we were talking about meditation. She's like, I just don't have time to meditate. And I'm like, well, what are you doing when I'm laying in here for 30 minutes with my needles in? She goes, I'm usually on my phone. I'm like, I don't know. That could be a time to self-meditate. Right. And she did. And she's like, I never thought about it. I was making all of these excuses, why I have to be at home, why it has to be this, why it has to be that for me to meditate. I just did it for 5 minutes. I feel great. So you can find 5 minutes to meditate. Having some green space in your surroundings, reading, can help if you like to read. It can also engage different parts of the brain. Laughing is important. Taking time off and actually using your time off for vacation, not working to catch up on your work during your vacation. You come back more re-energized, more reinvigorated and ready to go. I've tried working on vacation before. It's a disaster and I'm more frazzled when I come back than just taking a couple of days off. Eating well, we all know we should eat well, but if you can eat well like 80% of the time, you're doing pretty good. And sleeping is huge. Sleeping helps with cleaning the brain cells, processing everything through the day, not drinking too much before you go to sleep. Some days, aren't perfect. You might have too much wine, whatever, if you do drink, but, trying to consistently be on a sleep routine and prioritizing your sleep. Anybody binge watch Netflix? Yeah. It happens. They get you at the end, right? And you got to see the next episode. And there's a time where I'm like, nope. So I have a little thing on my phone and it goes, bring, bedtime reminder, Tina. And I'll be like, oh, but I want to watch the next episode. I'm like, nope, got to go to bed. The episode's going to be there tomorrow. It'll be fine. But since I've been able to prioritize that, I'm feeling a lot better. I'm feeling a lot less stressed. I'm not eating as much junk. I'm not drinking as much coffee. So being able to prioritize that too will really affect your self-care. And then finding what works for you. If you don't like walking, don't walk, right? If you don't like going to the gym, don't go to the gym. I used to go to the gym all the time and I really didn't love it. Some people love it. So now I have a Peloton bike, which was a COVID purchase because I was going bananas because I'm, an extrovert. I have a yoga studio that's 5 minutes away, right across the street, and I do hot yoga. My husband thinks I am, a little bit odd for wanting to go to a 104-degree yoga class and sweat, but I don't want to be outside and sweat in the Florida heat, but I'll go to a yoga studio and do this, for an hour. But for me, that it's very cleansing and it also taps into like my spiritual being and my overall being. So that works for me. That may not work for you. So all you got to do is find something that's easy to do, that's low-hanging fruit, that doesn't take a lot of effort to get to do, that doesn't cost a whole lot of money, and something that you just enjoy doing that doesn't really feel like work. When I go to yoga, I feel like it's a treat. I don't feel like it's work. I feel like it's me feeling better afterwards. So, you find what works for you. And if that's running up and down the stairs in your house, fine, right? But as long as you find what you like and it's easy to do and it's accessible, you'll be able to work that exercise in, even if it's only 10 minutes. Okay, so I guess now what we can do, a little impromptu self-care add-on lecture. Yes, the compassion fatigue. And then someone said the different lobes reminded me of the Phineas Gage. Yes, Phineas Gage is a very famous TBI case where a man was on a road and he got a pole like literally through his head. And he was like, I guess, probably one of the seminal like case studies of brain injury, and his personality changed. He became very aggressive, very erratic, and they're like, it's not the same old Gage. And so sometimes people's personalities do change after brain injury. So like I said, a little impromptu self-care. I don't know if I'm still sharing my screen, probably, but I'd like to open it up right now. We've got about 10 minutes, so I think we timed it. I'm not going to go back to those videos. You all have them. But at this point, oh, someone asked about research on brain injury and domestic violence.
Is there any way that, Dr. Dillahunt, is there any way that you could talk a little bit about that, or if you have any information on that with your expertise?
Yes, I can. And then I was reading that there's a new ED of the Brain Injury Association of Virginia. Whoever that is, David, hi. I'm here in Florida if you want any help. So nice to meet you. Were you down at the training in Clearwater? Were you at that training, the new leadership meeting? They were trying to get me to be a director of a new BIF, and they put me on as director. And I said, you guys, I'm a full tenure, I'm a full professor. I can't be your director. I'll be on your board. So they're trying to rebuild it. But I have friends. So let me know if you need anything to support you. So we got friends at NASHA, we got friends at BIA. Congratulations on taking that step. I want to share with you the brain injury and violence piece because it's very timely that you asked that. So okay. It's just interesting how things just work out, which is, I always get tickled when these things happen in these presentations, because it's like a natural progression of what people need in their education and training. And that's really exciting to me because I didn't plan for any of this. And now we have this. Okay, so I'm putting in the chat braininjuryprofessional.com. So Brain Injury Professional is through the North American Brain Injury Society, NABIS, and the IBIA, which is the International Brain Injury Association. And they put out a free newsletter, journal. It's kind of a newsy journal. So they call it the Time Magazine of Brain Injury. So I'm going to open that up. And I'm going to have to share my screen. And you guys are going to bear with me for just 1 minute because I can do it. Getting better. Okay. You guys seeing it?
We can see it.
Yay! Repetition works not only for people with brain injury. Okay, so the Brain Injury Professional. There are a bunch of different editions, so you can click on this, but the most recent one is called Brain Injury and Violence, Moving Past Closed Doors. This is free, available for download. And can you still see it?
We can.
Okay. So I just want to let you know, the topics in this are intimate partner violence and brain injury, intersection of psychological health and brain injury, assessment of IPV and health, multicultural considerations. There's an article on employment that I wrote after violence and brain injury, and then empowerment-based advocacy. So I actually co-edited this special issue with my colleague, Dr. Iverson at Boston. And we have articles from Dr. Valera. She has an IPV lab at Harvard, so she did that. We have Dr. Iverson from Boston on PTSD and violence. We have assessment, Dr. Fortier, she also is well known in the field of TBI and domestic violence. We have multicultural issues, some friends at USF, and then I with Dr. Rumrell, you know Dr. Rumrell, he's on here with his son Stuart, the other Dr. Rumrell, and we talk about employment and violence after TBI. And then empowerment-based advocacy and care in the abused and brain injury toolkit. So there's a toolkit in here too that's very helpful for you all. It offers a framework. And then we have an interview with my colleague, Dr. Snedeker. She runs the Pink Concussions for women with brain injury consequential of IPV and DV. So this is here, and this is free, and you can download it at any time. They also have a best practices or in concussion management. The one in September was health equity in TBI. We had one on constraint-induced movement therapy, acquired brain injury and family intervention was one they had in 2020. Cognitive rehab updates and work reentry. They have one on TBI and work reentry. And then that was the one I also had, which might be relevant to you all, the TBI and work reentry. So I had a couple of articles in this one. And again, this is free. And I like to share the resources that are free and accessible, because if you're not with a university, they like ask you to pay like $50 for an article, which is absolutely ridiculous and unacceptable. The NIH is moving towards making all of the published research related, that's got published articles related to federally funded projects should be open access, because federal dollars are being used to fund that research. So there's a move right now to try and get this information available to the public at no cost, because it doesn't really make sense that people want to read something and then they can't access the materials. So that's why I like the Brain Injury Professional, because it goes out to 60,000 people internationally. So the brain injury, one on work and brain injury, has current research on return to work for veterans with TBI. I worked on that article. We've got one on polytrauma, one on effective voc rehab services, improving employment and post-secondary education outcomes of young adults with TBI. Again, you'll see Dr. Rumrell there. And there's also one on customized employment and return to work with individuals with TBI. So for those of you that are more interested in the discovery customized employment process versus supported employment, you can find some pretty good information there. So I hope that was kind of a long-winded answer to do you know, can you talk about intimate partner violence, domestic violence, and TBI? I recommend maybe just going to this free article that just came out 2 months ago now.
No, thank you. Thank you so much for that. I know even in the chat, people are saying that's just a great resource to have. So thank you.
Mm-hmm. And if I may, I know we're at the top of the hour, I would like to share with you that model systems, because I really feel like this is where you guys are going to get what you need to work with your clients. Okay, one more share. And the thing is, this information is out here. You know, it should not be, you know, it should not be hard to find, and it should not take someone, you know, like you just finding it by chance, by happenstance, right? So the more you all learn about this stuff, the more I think you can share. I'm trying to share my screen here. Share this with others, because this stuff exists and it's really good. What's out there? Yeah, here we go. Okay. And I love this resource. I use it all the time, especially when I'm working with families. So it's called the Model Systems Knowledge Translation.
And right now we can
probably look at your desktop.
Oh, okay, let me try this. Do you see it now?
We do.
It says Model Systems Directory?
Yes, Model Systems Directory.
Okay. Okay, so there's the model systems. And so they collect a lot of prospective data for spinal cord injury, traumatic brain injury, burn injury. They have also in Spanish. So in Florida, it's really important for us to have most everything available also in Spanish and or Creole sometimes. So this shows you where all the model systems are. But what I think is more important is this traumatic brain injury link, where you can go in and find out about information that living with the TBI. So you have a client and they have TBI and you don't know about, you want to work with being a parent with a traumatic brain injury, alcohol and TBI, memory changes after brain injury, driving, emotional problems, fatigue, headaches, rehab programs with DOC, disorders of consciousness, relationships after TBI, going back to school. This might be helpful for the individual in the chat who had a daughter who had some things going on at school, who was 9 years old, severe TBI, sexuality after TBI, sleep and TBI. So you name it, they've got a fact sheet for it. And it's great. You can come in here, you can go into Understanding TBI, and you can click on these fact sheets, you know, the impact of recent TBI on the family member and what they can do to help them recover. They have info comics. They sometimes have podcasts and videos. So the wealth of information here can be a bit overwhelming, but if you know what you're looking for that's targeted, you can probably find it. and learn more about the prospective data that's being connected. So you'll see here, medication and memory problems after TBI. This is Angel Sander. She's in Houston. She's amazing. She does incredible work with TBI and community reintegration. And the more you get involved in the TBI world, the more that you'll find that it's a lot of the same people. And there's like a handful of people that are doing specific research in these targeted areas, and they really are the experts. And so I know if I see an article from them, it's going to be evidence-based. It's going to be, going to have the high level of rigor that is needed in these types of studies and interventions that are being developed for these folks with brain injury. So I'll put this in the chat as well. I'll go back to the main one though. Let's see. I'm going to go to the chat. And then, there's the link to the model systems. I know it's time to go. It's 3 o'clock. I kept you guys on the dot. I'll stick around for a couple extra questions if you want it. But the more we can share information, the more we can educate ourselves, the better we can do in our work. And oh, good. I'm glad it was fun. I'm sometimes all over the place, but I'm quite passionate about what it is. And like I said, I'm a voluntary guardian of an adult sibling with a brain injury. So, this is close to the chest. So, alrighty, you guys, I'm going to hang out and let you guys tell me when I should log off.
Thank you, Dr. Dillahunt. As advertised, this has been great. It's been an honor and a privilege for you to join us today on behalf of HDI. We are so grateful for your time and for your willingness to share your expertise. I do have one quick announcement.
Sure.
We have upcoming, we have another HDI webinar, and some may be interested in it. Its title is Disability Pride and Prejudice, Beyond the Self in Advocacy. And I am going to drop into the chat. I have got it copied already. I have just pasted it, and there is a link to register. And that again, that's the title is Disability Pride and Prejudice, Beyond the Self in Advocacy. It's April 14th. April 14th is a Friday. It's from 1 to 3 p.m. Eastern. The moderator is Bev Harp. We would love to have you join us. Thank you, Dr. Dillahunt, for this informative presentation.
All right. You guys have a great day.
Be well. Stay safe. Thank you.
Bye.